Good morning, everyone. So my topic today is complement-mediated disorders of pregnancy. It's a very theoretical topic and perhaps something that all of us are a little less familiar with. So this is why I thought it would be a good idea to, as the coordinator of this program, I invited myself to give this talk because I thought it's something we should all become a bit more familiar with. So it's probably not that uncommon, it's just that we are not recognizing it and we are all less aware about these conditions. And in our country, our diagnostics are still very limited, so there's a lot of room for improvement there. And even when it comes to management, our treatments are also very limited. So again, there's a lot of room for improvement. So it may be that, our management is not going to change much at the end of this talk, but I think at least we will know where we are deficient. So this is a case, probably something similar to what you may have seen before. This is not a true case, but I adapted it from a case report. So just think of it, a 26-year-old woman in her first pregnancy, coming at 38 weeks. She's in labor, she's hypertensive, she has elevated liver enzymes, AST of 600 and ALT of 300. She has proteinuria, she has a AKI, so her creatinine is 137. And she's got low HP, low platelets, and a MAHA on the blood picture, and LDH of 1600. So you may have come across many, many patients like this in your care of obstetrics patients and also in nephrology. So you can pause for a minute to think of what your differential diagnosis would be at this point, right? And we'll be coming back to this again at the end of the talk. So my topic is complement-mediated disorders of pregnancy, and these are the four main entities: pregnancy-associated atypical HUS or TTP, preeclampsia or the HELP syndrome, SLE and antiphospholipid syndrome, and peripartum cardiomyopathy. So my talk is going to focus on the first two, that is pregnancy-associated atypical HUS and preeclampsia. Now, we can't talk about complement-mediated disorders without going through the complement pathway. So you must remember some of this from medical school. There are three arms of the complement pathway. There's the classical pathway, which is activated by antigen-antibody complexes. There's the alternative pathway, which is again activated by bacterial products, but is in itself always activating itself, constitutionally active. And then there's something called the lectin pathway. And all of these pathways, they converge on a common final pathway, which is called the terminal pathway. So the outcome of whichever this pathway, which leads to the terminal pathway, is acute inflammation, opsonization, and formation of the membrane attack complex. So these complement pathways are innate immunity. The reaction that it has is not specific to any particular agent. So what do we mean when we say disorders of the complement system? Disorders arise because of dysregulation of this pathway. So either the pathway can become underactive or overactive. So underactive is when patients' complement pathway is not working properly, they can become immunodeficient, right? But that is not what we are talking about today. Today we are talking about dysregulation, where it's actually overactive because this regulation is not there. And you are familiar with this concept from autoimmune diseases, right? So in autoimmune diseases, your autoimmunity is acting against yourself. It's out of control. Similarly, when the complement pathway is dysregulated, again, it's attacking your body. So why does this happen? It can happen because of either genetic problems or inherited factors. So if it's a genetic problem, it should be something in your genes, and these genes can be related to the various proteins in this pathway. So there are proteins which are the components of the pathway, and there are proteins which regulate the pathway. So whichever, if there's a problem with any of these, you can get dysregulation. And also HLA, because we know the classical pathway is stimulated by the antigen-antibody complexes. And then you can have acquired problems. So acquired problems are if you have antibodies formed against these regulating proteins, and they are not letting these proteins do what they are supposed to do. So in either of these case situations, you can have dysregulation. So usually, even if you have a genetic abnormality, even if you have antibodies, the disease doesn't become manifest until there's a trigger. So what are these triggers? Triggers which activate the complement system. So antigen-antibody complexes, for example, infections, drugs, alloimmunity, malignancies, and so on, right? And similarly, the classical pathway. So you need another trigger for the disease to become manifest, usually. And the outcome is something like a thrombotic microangiopathy, so atypical HUS as an example, and glomerular diseases. So just to sort of schematically explain what I've already said, if you have a genetic or acquired dysregulation of the complement pathway, you get unregulated complement activation, and that leads to a complement-mediated disease. We call it primary if there's no other explanation for it, no clear trigger identifiable, and there are entities like that, right? But the complement pathway gets activated anyway in the normal processes, like on exposure to infection, drugs, toxins, and auto and alloimmunity. So you can get a secondary complement-mediated disease because of one of these triggers if the pathway gets activated out of control. So there may be a genetic predisposition to get these secondary complement-mediated diseases, but not always, right? So why are we talking about this in the context of pregnancy? Pregnancy is a very special situation where there is an alien life inside the mother's body, and the body will naturally try to attack that because it is non-self. So the mother, there has to be what is called maternal placental immune tolerance. That means the mother has to immunologically tolerate the baby, and the interface at which this happens is the placenta, because that's where the two meet. So you have to balance preventing rejection of the fetus with maintaining your immunity to fight infection. So how does the body achieve this? One thing is, there's predominantly suppression of the acquired immune system, with the innate immunity being increased through the complement pathway. So complement pathway is more active in pregnancy, in summary, right? And how is the baby protected from this? The placenta produces certain regulators of the complement pathway, which protects the baby from this extra complement activity. So this is a very, very delicate balance of increased complement activity and increased complement regulation. So if there's an underlying disorder, either genetic or acquired, which reduces your ability to regulate the complement system, then this pregnancy can pose as a trigger to cause disease. Okay? So a little bit more about pregnancy-related TTP and atypical HUS, because that is what is a little less familiar to us. It is characterized by thrombotic microangiopathy, and thrombotic microangiopathy is MAHA, thrombocytopenia, and organ ischemia. That is the triad, right? And when you think of it from a pathogenetic perspective, you can think of it as three types of pathological mechanisms occurring. So there's complement activation, thrombosis, and endothelial injury. And this is seen in any kind of TMA, but in certain TMAs, one component is more common than the other. So in our complement-mediated TMAs of pregnancy, it is complement activation which is the trigger, the starting point, and the rest of it all follows. So TTP and atypical HUS are two different entities completely, but I just need to speak a little bit about TTP because it is an important differential diagnosis, and it is more common in pregnancy. It's characterized by the presence of what are called large 1 millibrand factor multimers in the circulation. So in pregnancy, you produce more of these. And these can cause platelet aggregation that will cause microvascular thrombosis, tissue injury, and this whole TMA cascade. So usually, these multimers are cleaved by a protein called ADAMTS13 protein. Now in pregnancy, the levels of this protein also drop. So now you have more of the multimers, these large multimers which can cause platelet aggregation, less of the protein that breaks down these multimers, and therefore you can get a TTP, right? And complement dysregulation also may play an additional role in the injury that occurs in pregnancy-related TTP. So there is complement-mediated damage also occurring here, right? Now, if you think of that case, there was a MAHA in that case, right? So it's probably a TMA, right? And when we approach a patient with a TMA, we have to have a systematic way of evaluating. And it's challenging because we don't have many of the tests that you need to do, right? So when you have a TMA, one of the first things you need to exclude is a TTP. The ideal way to do that is to look at the ADAMTS13 activity, right? So again, now we can't do ADAMTS13 activity in Sri Lanka, but there are certain clinical criteria which we can use to suspect a TTP. For example, if there's a lot of hemolysis, very low platelets, and if there's quite severe kidney injury, then it is less likely to be TTP, more likely to be an atypical HUS. But that is all just guesswork. The real diagnosis is with the ADAMTS13 activity measurement. So why is it important to know? Because the treatment is plasma exchange, right? So often what happens is we aren't able to differentiate because we don't have the tests, so we start plasma exchange anyway, right? Because otherwise the outcome is very poor. Now if we had the capacity to exclude a TTP, we would do that, and then we are left with the atypical HUSs or the HUSs. Typical HUS is when it's associated with a toxin-producing bacterial infection which causes diarrhea, right? And I mean that is more common in non-pregnant patients, but in pregnant patients, of course, they can get it, but then you have to suspect a pregnancy-related TMA, right? So there are once you've come to the conclusion that the patient has a non-TTP TMA, now you have lots of differentials, and one of the important things is pregnancy in itself, right? So here we have that pathway again. We have our genetic or acquired dysregulation leading to complement activation, endoendothelial injury, and primary atypical HUS, right? And it can be also secondary atypical HUS, and sometimes there is a genetic predisposition, but it's not so common except in pregnancy, where up to 70% of people who develop this atypical HUS, right, whether or not there is a trigger like infection or drugs, have a genetic risk factor, right? So pregnancy is a stressor on the complement system, and it makes this genetic abnormality apparent. So here are some facts about atypical HUS in pregnancy. The incidence is about 1 in 25,000 pregnancies. It accounts for about 20% of all atypical HUS cases, so that's quite a lot, right? Majority occur in the postpartum periods. That's quite interesting because the differential here is HELP, preeclampsia and HELP, and that we know that preeclampsia recovers after delivery of the placenta. The outcome is very poor, right? Because a lot of patients go into end-stage kidney disease, especially in the pre-eculizumab area. So eculizumab is a drug which antagonizes this complement activity. So we are in Sri Lanka don't have the drug, so our outcomes are poor. And if you find that there is an underlying genetic variant, right? So we said 70% have a genetic variant. Depending on what that variant is, the outcomes again may differ. So why is atypical HUS becoming more common in the postpartum period? Because you have all this complement activity happening in the maternal circulation, but the the placenta has certain factors like CD59 and DAF which regulate this complement activities that is normally present in the placenta. And that keeps things under control. After the baby and the placenta are delivered, now these regulators are not there, so therefore you get all this complement activity going on unregulated. And that is why in atypical HUS, the disease becomes more severe postpartum. And also this peripartum period is full of triggers for the complement system. So there's bleeding, there's infection, fetal cells are getting into the maternal circulation, and there can be exposure of HLA antigens, so there's an alloimmune response. So the additional insult of more triggering of the complement pathway also occurs in this peripartum period. Okay, so that's about atypical HUS. Now the other differential that we have in this situation is preeclampsia and HELP, which we are much more familiar with, complicates about 3 to 4% of pregnancies, and it is, as was discussed, associated with abnormal placentation. So at least in some cases, there is evidence of abnormal complement pathway activation even in preeclampsia and HELP. It may not be the cause, it may be the cause, we don't know, but it may be at least contributing to the severity of how the disease manifests, right? And there's data from animal studies, in vitro studies, and even in vivo small case studies to support that complement is involved in at least the more severe cases. what's happening is there's an imbalance between complement activity and regulation. And in some cases, not many, there's a genetic predisposition to complement dysregulation. So we talked about earlier in the talk on preeclampsia, there was a discussion about how we use what is called soluble FMS like tyrosine kinase 1, SFLT1, and placental growth factor to diagnose preeclampsia and to assess the severity. So basically, placental growth factor is helping the maintain the healthy vascularity of the placenta, and this SFLT1 is antagonizing that. It is an anti-vascular growth factor. So the more SFLT1 you have, and the less placental growth factor you have, the worse it is for the vasculature of the placenta. The placenta becomes ischemic, and the placenta becomes ischemic, and you get this preeclampsia happening, right? So these vessels are not only present in the placenta, they are present in other tissues, so that's why you get hypertension and proteinuria when the anti-angiogenic effects are more than the pro-angiogenic effects, right? Placental ischemia leads to inflammation. Inflammation, we know, causes complement activation, and complement activation in turn, when there's active complement, you get more of this SFLT1 being produced by the monocytes and the trophoblast. So now you are in this vicious cycle where you started with placental ischemia, you activated the complement pathway, and now everything is getting worse and worse. So you see this in preeclampsia. Once it starts, it just keeps getting worse until you can get rid of the placenta, right? So complement is playing some role. And I think we all feel when we're managing a patient with preeclampsia that this is something not really in our control, right? Either for good or for bad. You don't have the responsibility of, trying to reverse the cause, but at the same time, there's nothing you can do. So it's quite interesting that maybe there will one day be at least some role for complement inhibition in the more severe cases. So there are case reports still, but this is not established practice. Right, so moving back to our case, now we can remember this young woman who is at risk of, who is less at risk actually of preeclampsia than it's the older patients, but in her first pregnancy, 38 weeks, so towards the end, right, when preeclampsia becomes more common, high blood pressure, AST, ALT, yeah, so ALT is a little bit higher than ALT, so you need to suspect that there may be some hemolysis going on. She's got an AKI, and the blood picture is also supportive of a hemolytic anemia, right? So now we have some differentials. This may be HELP. That is what the first thing we would think of. This could be an atypical HUS, right? And this could be something else. So she could be having bleeding and DIC. She could be having sepsis and DIC. There are other differentials also that come into mind. So how can we differentiate HELP and atypical HUS? So this is an interesting study where they compared patients with HELP and atypical HUS to see whether you could predict which it was. And what is evident from this study is if the renal impairment is severe, so if the creatinine is more than 1.9, there's a very strong chance that this is atypical HUS and not HELP, right? And if that is associated with evidence of significant hemolysis with an LDH more than 600, again, it is very, very suggestive of atypical HUS. So that's something I think we can keep in mind. Also keeping in mind that these patients may have other reasons for AKI other than this MAHA, like sepsis, bleeding, and so on. Another important thing to keep in mind is the time course. So if it's a HELP, usually once the placenta is delivered, within 72 hours, things should start to improve, right? Whereas if it's an atypical HUS, usually it doesn't improve, and that's when we start to suspect it, and then they can progress to severe kidney failure. So we can suspect it before waiting for 72 hours if we consider other factors like the severity of the kidney dysfunction and the degree of hemolysis. So in this patient, what would we generally do? Now she's already in labor, which is always a relief, I think, because the baby is going to be delivered, and that half of our problem is solved. So she delivers, and what we would normally do is wait and see. So we are waiting to see whether the patient's disease is going to settle, and that is what we expect in a HELP, right? Based on these findings, we should also suspect that this is not HELP, right? While we are waiting for this to recover, we might look for other causes that can cause this kind of MAHA, right? Is there any PPH? Is there sepsis? Is there any reason to suspect SLE or antiphospholipid syndrome? Maybe even could this be a TTP, but again, the degree of renal involvement is not really supportive. The platelet count is not that low, right? So some people might start Plex, some people might just wait. What is the ideal management? Ideal management, if you had the option, would be to start complement inhibition for this patient as soon as possible, because it improves the outcomes, right? We don't have it here, but that I think we still need to be aware that these treatments are available, right? And some people might actually start complement inhibition earlier, just simply based on this picture, right? Plasma exchange, it's very controversial. So the place is really for TTP, not so much in atypical HUS. Plasma exchange is helpful if there's an antibody, which we want to remove, right? So an acquired cause of TMA. And you actually might be doing disservice by doing plasma exchange, because you may be giving the patient substrate or giving the complement pathway new substrate for more and more injury to occur. And then ideally, this patient should have genetic studies which would influence the management. So these are some of my take-home messages. Disorders of complement are being increasingly identified as causes of AKI in pregnancy, and complement-mediated TMA should be considered in the DD of a patient with a TMA in pregnancy. Severe AKI and failure of the parameters to improve within 72 hours after delivery are a clue to a TMA. When I say TMA, I actually mean atypical HUS. Some cases of preeclampsia may be worsened by complement dysregulation. I think that's an interesting area in the literature to follow in the future, because there may be treatments evolving there. And finally, in our context, better diagnostics and treatments should be made available for managing these patients. So thank you very much.